So I'm very excited to introduce our next speaker, whom we've heard from before, Dr. Sidransky at the NIH. And she'll be speaking on 15-year evaluation for prodromal Parkinson's features in an at-risk cohort for PD. So actually, Zid will, sorry, it'll be faster.
While he's getting it, I want to thank Steve. I think this has been an amazing conference with a lot of exciting work presented. So, for about 15 or maybe even more years, we've been following patients to see if we could find early clinical or imaging features that might be predictive of Parkinsonism in our cohort with biallelic and single mutation carriers of GBA1. So this is work mainly conducted by Grizel Lopez, who couldn't be here. And the subjects that we've been recruiting, there's a PD group, which are patients that have both Gaucher disease and clinical Parkinson disease, and also Gaucher carriers with Parkinson disease. And then there's our at-risk group, which is our patients with Gaucher and carriers that don't have PD, but have most of them have a positive family history. When they come to NIH, each visit they undergo physical neurologic examination, full neurocognitive evaluation, olfactory testing with UPSIT, and all kinds of screens and questionnaires for non-motor symptoms. And then we've been doing some imaging studies. For many years, we piloted a fluorodopa PET and also radioactive water. And at the same time, we're getting MRIs. And we've been collecting transcranial sonography results. So about 155 patients were followed during the course of this study. Of the 155, 30 had Parkinson disease. Of these, 11 were female and 19 were male, and 125 didn't have Parkinson disease. And here the ratio is shifted with more females than males. And in this cohort, 92 were patients with Gaucher disease, and 63 were Gaucher carriers. So again, single center 15-year study with a single neurologist and a single neuropsychologist until she retired a few years ago. And it included an 11-year-long PET study, and we've been doing transcranial all along. So start with our patients that do have Parkinson disease, the 30 that I mentioned. They tend to have many clinical and pathologic findings that resemble idiopathic Parkinson disease, though some have had DLB features, both clinically and, more importantly, pathologically. Most respond to levodopa. The earlier age of PD onset, our mean was 49. They are more likely to have a positive family history. They have non-motor symptoms, and olfaction is generally impacted in almost all. There's some indications that progression is faster and that there's more cognitive dysfunction, but I always like to say not always. We've seen exceptions, and I'm somebody who always likes to cherish our exceptions. And I often show this panel of 3 patients that we've seen over the years. The first woman had her onset of Parkinson's disease in her 40s. She had about a 28-year course and only developed cognitive changes late in her course. This gentleman, in contrast, showed up in his late 50s, very mild Gaucher disease, but he was already confused when we first evaluated him. He died very soon afterwards with severe cognitive dysfunction. And the third patient was one that was sent by Ari Simron, a professor from Israel who knew 9 languages, and he died at onset in 60s, died at age 78 from cardiac complications, and appeared to have normal cognition the whole way through. So quite a spectrum. So I mentioned our imaging studies. We did fluorodopa PET and transcranial sonography measuring regional brain dopamine synthesis and the nigral echogenicity respectively. The PET studies were with Karen Berman at NIMH. And as you can see from this figure, our patients with Gaucher and Parkinson disease really resembled, the pattern of dopamine loss really resembled what she had collected previously in idiopathic Parkinson disease. We actually did sequential PET studies, and this has all been published, and saw no difference in rate of dopamine loss over time between at-risk subjects and controls. Likewise, with the transcranial, you can see that our patients that we knew had Parkinsonism did have increased echogenicity, but those without really didn't differ very much from those without Parkinson's disease. Gave us an opportunity to compare the two modalities, and we saw a nice inverse relationship in those patients that had Parkinson's disease, but no correlation at all for those that didn't. So we see larger echogenic areas and reduced striatal Ki only in the patients with clinical Parkinson's disease, but not in our at-risk patients, even over time. In fact, one patient that we had that converted had a normal PET less than a year before he was diagnosed with Parkinson's disease. So for us, neither modality seems to be predictive. We stopped doing the PET study. It's too high, too costly and hard on the patients. Evaluation of olfaction. In this collection, we had 117 participants, some with Gaucher, some carriers. And really the only group that clearly had impaired olfaction at baseline was the series with patients, either carriers or homozygotes that clinically had Parkinson's disease. And then we followed as much as we could the at-risk group. This is with family history, without family history. You can see that some patients had low APSIT scores, but it didn't seem to deteriorate with time. And as you know, there's lots of reasons why you might have impaired olfaction. It's especially hard now after COVID to evaluate this. We looked at non-motor features. First of all, we did cognitive testing for our English speakers, so we have a pretty smart cohort. We didn't see significant differences in cognition in the first visit, and we only observed deterioration over time only in the Parkinson cohort. The longitudinal assessments in the at-risk group showed no trends over time. We also did these questionnaires for non-motor symptoms, 30 items, 10 domains, self-reported, and really the only group that was abnormal were those that had Gaucher disease and Parkinson's disease. And when we looked at our at-risk group, there was no consistent increase in progression to abnormal scores over time. So to tie up what we saw in our at-risk group, again, we had both homozygotes and heterozygotes, most with a family history, often a parent or sibling. We only had 2 converters in the course of this whole study. We didn't see changes in PET. We didn't see changes in transcranial. The upset was slightly lower in the Gaucher group, probably because we had those few that had problems with olfaction, but we didn't see changes over time. About 4 subjects went to autopsy for other reasons, with death from other reasons, and when we looked at them, we saw no Lewy body pathology, and again, only 2 developed Parkinson's disease. So clearly we need longer follow-up and larger cohorts, and most of our patients are not on a Parkinson's trajectory. This is all very good news for our patients, but it's very frustrating as an investigator to invest so much time and really not pick up that many converters. So what's the story with this low penetrance? Well, it's clear that GBA mutations are just a risk factor, and so our challenge is really to find the other genes or risks that either increase or decrease our risk for Parkinson's disease, both by these clinical evaluations, but the time's really ripe for multi-omic approaches. And the only problem is that a rare disease, we have a small sample size, and so I just want to give a pitch that collaborations are really going to be important for evaluating genomic results. Well, one group that we've focused on are been SIB pairs, and at this point we have evaluated 10 SIB pairs where, this is wrong. This is correct, where all of them have Gaucher disease, but one has only Gaucher disease, and a brother or sister has Gaucher and Parkinson. And so these siblings have been seen 1 to 8 times over the last 18 years, and each time we do the whole battery of evaluation, and we've done whole genome sequencing and a lot of other things, but thus far we haven't seen any indications of Parkinson's disease or changes in PET scans or transcranial in the non-PD SIB. Each time they come, we do store multiple samples, because I really think that these kind of studies might help us identify risk or predictive alleles for Parkinson's disease. Another thing that we've been doing from these discordant Gaucher siblings is generate iPSC lines. Ellen Hertz, who was a postdoc in the lab, took 3 different SIB pairs. One of them actually had a wild-type sister as a control, and differentiated these into iPSCs and then into glutaminergic and dopaminergic neurons, did the appropriate quality controls, and then it's been studying the disease phenotype. Interestingly, we've seen no differences in enzymatic activity nor glycolipid storage in the neurons between the siblings and the SIB pairs. Some RNA-seq suggests some enrichment of pathways modulating post-translational modification in the Parkinson, but we still are continuing these evaluations. So in conclusion, our heterozygotes and homozygotes clinically seem to be fairly similar with an earlier onset, impaired olfaction and cognitive changes. In the group without Parkinson's disease, we haven't seen anything when looking at imaging, olfaction, cognition, and non-motor features. Among our 125 at-risk individuals, we only had 2 that converted. Transcranial and 4 dopa PET weren't really useful. Cognitive testing, at least so far, hasn't identified patients on a trajectory. SIB pairs are going to be important, and collaborations are going to be needed to increase the statistical power. I want to thank my team, especially Grisel Lopez and Emery Ryan, my clinical team, all my collaborators, and give special thanks to patients, family members, caregivers, and referring physicians. Thank you.
That's fantastic. Thank you. And it raises so many questions. If you'll forgive me, I just want to ask you, the phenoconverters, anything about them? Were they normosmic before phenoconversion?
So one was a carrier and one was a patient. And the carrier, I think, was normosmic. There was nothing to suggest anything beforehand. The patient was one of the very first we ever saw, and she had a lot of psychiatric issues beforehand, so I don't know what that meant. It was also addiction issues, so it was complicated.
Okay. All right. Thank you. And should we get one more question? Yeah.
Do you have any idea what, for example, the seed amplification assay from skin or CSF would look like?
We haven't done it yet. Bottom line.
All right. Thank you so much. That's great. And next, also from the NIH.